Alright, so we'll do some thyroid nodule stuff now, and uh, most of these are asymptomatic, and they're really just found when somebody goes to the doctor and they swallow during the exam and they find a little cystic nodule. They're really common, actually. But anytime somebody has a thyroid nodule, there's two tests they should have done: a thyroid ultrasound and a TSH level. So the ultrasound findings are mostly what's going to dictate what we do from there, and suspicious findings are the same as suspicious findings for any malignancy that I've encountered the past few weeks, which is just not completely cystic, has a solid component, irregular borders or calcifications. And if it's purely cystic and it's completely round, it's probably okay. Then with the TSH, that's where it can get a little bit more interesting here, because if it's normal or if it's elevated, suggesting a little bit of hypothyroidism, that means that this might be a cold nodule, and in that case, we may want to do further workup for malignancy. However, if the TSH comes back and it's low, then that's consistent with hyperthyroidism, and the next best test from there, as in any patient with hyperthyroidism, is going to be to do a radioactive scintigraphy study. So once we have done those two tests, we can interpret them, and uh, we'll start with somebody who seems like they have hyperthyroidism based on a low TSH. And we do the scintigraphy. If it's diffuse uptake, it's Graves' disease, slam dunk, we're done. But do be mindful that somebody with Graves' disease can get cancer eventually, and the key to that would be if they have diffuse uptake other than one spot. Somebody with Graves' disease on scintigraphy that has one little cold nodule. That nodule should then be, the ultrasound findings should be looked at, and if they're suspicious, they probably need a biopsy. If they have focal uptake, then it's a toxic adenoma. And then if there's multiple areas in a cold area, it's probably cold areas, excuse me, then that's probably toxic multinodular goiter. So then if we have people, on the other hand, who don't have hyperthyroidism, we have to use the ultrasound. And if they're suspicious on ultrasound, we need to do an FNA, a fine needle aspiration. And the other hand here is that if they tell you that the ultrasound is completely cystic and it looks beautiful, then we don't have to biopsy it and we can send this person home and they're no worse off. And now I wanted to cover a few specific interesting ways that the scintigraphy study can be used to trick you on the exam. We do this again with just about anybody who has a low TSH when we think has hyperthyroidism. So let's say somebody had thyroiditis because they had a recent, infection, viral infection. Now they have that post-viral thyroiditis, and they have the fever and the tender thyroid. And the classic finding on scintigraphy is a low uptake, and they have low uptake in this case because the virus has destroyed the cells, and so the cells aren't there to take up the thyroid. And the mechanism of hyperthyroidism symptoms in this case, is because the cells release all that thyroid hormone into the blood. So, and then again, just to remind you, Hashimoto's can initially present in a similar way with a transient thyroiditis. And then let's say somebody is abusing thyroid hormone to lose weight, or they're taking too much of their levothyroxine. In that case, you would again have low TSH, and the scintigraphy would show low uptake throughout. But that is an easy one to sort of tell apart from the thyroiditis because they don't have a preceding viral infection or they're not tender on exam either. And the way you tell if someone's abusing thyroid hormone is to measure their serum thyroglobulin level. So remember that test and remember how you can use it. And then let's say someone has a multinodular goiter picture and they've got a few hot nodules that are clearly hyperfunctional, and then they've got this one cystic nodule that is cold or not functional. And that nodule should be worked up the same way that we'd work up any cold nodule in anybody else, with the FNA based on how the ultrasound looks. So we'll get more to the details about that now. This is for cold nodules. We don't do this for hyperfunctioning nodules. And let's say we do an FNA and it's normal, then they can have a new ultrasound in 1 year. But in the event that the question tells you that the aspiration came back with a likely cancer or cells that are suspicious for malignancy, the best answer from there is not going to be to watch and wait under any circumstance. It's going to be surgical removal of part or all of the thyroid gland. And this is actually something that still surprises me now, but it was on my medicine shelf. It's a surgery question. My question was the patient had a thyroid mass and they had an ipsilateral enlarged lymph node. So let's backtrack here. If they have a mass on the thyroid or a nodule on the thyroid, and there's no enlarged lymph nodes on exam, and the pre-op ultrasound, and they'll give you this on the question, there's no enlarged lymph nodes, then all you have to do is a thyroidectomy or even a partial thyroidectomy. However, if they have lymph node enlargement, you do the thyroidectomy and they get an ipsilateral lymph node dissection. That's what was on my shelf, and I cannot believe it, but I want you to know that because I want you to do better than I did. So after surgery, this is, if they ask you what could you do adjuvantly after surgery, you could give them an iodine ablation to try and knock out any residual thyroid tissue they have throughout the body. And then if you wanted to, use a tumor recurrence marker, the thyroid globulin level should be gone after you take away the thyroid surgically. So somebody who has an increased thyroid globulin level later on, years later, suggests recurrence of thyroid cancer. And I just wanted to give you an overview of the different kinds of thyroid cancer. I don't think I need to go through this in detail with you. Be aware of the risk factors and know the papillary is most common, spreads to the lymph nodes. And then follicular cancer, also be mindful that fine needle aspiration cannot diagnose follicular cancer because the cells look about the same as cells from an adenoma do. So you really have to diagnose it by taking it out. So these patients, if you get a fine needle aspiration comes back with follicular cells of undetermined significance, that patient needs to have a thyroidectomy. And then just remember that medullary thyroid cancer is part of the multiple endocrine neoplasia syndromes, specifically 2A and 2B. And then anaplastic thyroid carcinoma, a question they might give you on that, somebody who had follicular or papillary thyroid cancer and didn't seek treatment can end up getting anaplastic or undifferentiated thyroid cancer.